Take care of your body by RIDE. A healthy lifespan must become a priority. Keep listening to see what's next.
I hope you're smiling because it's me, Rye. Today, my guest is world-renowned Dr. Camillo Ricordi. Dr. Ricordi is professor of surgery, distinguished professor of medicine, professor of biomedical engineering and microbiology and immunology, Cell Transplant Center, and director emeritus of the Diabetes Research Institute at the University of Miami Miller School of Medicine. He's a National Academy of Inventors, fellow at the University of Miami, where he serves as chief of the Division of Cellular Transportation, Department of Surgery. He was knighted by the President of the Republic of Italy in the highest order of the Republic for contributing outstanding inventions that have made a tangible impact on the quality of life of numerous individuals. He is also a longtime friend that I have been extremely honored to know my whole life. Thank you so much for joining me, Dr. Ricordi. It's truly an honor.
Thank you, Ryling, for having me.
I'm,
And a
yeah.
nice presentation. The only imperfection was cellular transportation. That should be cellular transplantation, but the rest is pretty much good, all good.
Thank you so much. And you truly have amazing titles. I am very inspired by you, and you've motivated me to keep going on my journey because you've done so much in your life. So
Thanks, you're too generous.
very inspiring. So, are you ready to have a little bit of a conversation about health and all the amazing research that you've done?
Sure, please.
Can you describe type 1 diabetes and the impact that it has on an individual's health?
Yes, well, type 1 diabetes is one of the main form of diabetes. There are several subgroup of diabetes, but the two most important are type 2 and type 1 diabetes. So while type 2 diabetes is mainly linked to nutrition and lifestyle, lack of exercise, sedentary life, and wrong nutrition, and can be prevented more than 50% just by exercise and diet. Type 1 diabetes is an autoimmune disease where the immune system is unable to counteract triggering events of an autoimmune disease. That means when the immune system doesn't recognize a part of your body any longer as self, as part of your own body, and start attacking it. And type 1 diabetes has a genetic risk, meaning that there are risk factors genetically transmitted that are very rare, though. It's 1 in 300 possibility that you can develop diabetes if you have this gene. But at the same time, if you have a sister or a sibling or a relative with type 1, the risk increase to be like 1 in 20. And so that you already know that this risk factor, if you have wrong situation in your body that make you unable to react to a triggering event of autoimmunity, then you can start this slow, can be fast or slow, can take years to develop fully, or can be very fast in neonates, but it can be preceded by genetic risk factor that evolve then in the appearance of these so-called autoantibodies that are antibodies against part of your own body. But still you can spend years with these antibodies and without losing the insulin producing cells of your pancreas. And then eventually this evolves towards beta cell dysfunction. That means beta cells are the cells that produce insulin containing your pancreatic islets that are this precious little load of the pancreas that is 1 to 2% of the pancreas, but is represented by this microscopic hundreds of thousands cell cluster that includes the insulin producing cells. And when the attack selectively hits these insulin producing cells, then you have the clinical diagnosis of type 1 diabetes and you start requiring insulin. Like sometimes you have a period so-called of honeymoon because there is a first acute onset and then the inflammation to the pancreas and the destruction of these insulin producing cells can subside for months or even 1 year or longer. And but then eventually the progression is towards destruction of all the insulin producing cells or most of them. So that's is a little long description of the.
No, I really find it so fascinating, and I know you've done a lot of research on it. So do you want to explain your past and current diabetes research and what it strives to accomplish?
Yeah, so tradition in the last decades, I mean 4 decades since the 80s, we've been working to try to treat the most severe cases of diabetes where you lose completely all the insulin producing cells and then trying to isolate and transplant these pancreatic islets, this microscopic structure that are spread throughout the pancreas in hundreds of thousands of microscopic organs, but that represent only 1 to 2% of the whole pancreas. So for decades, there has been a lot of challenge separating this microscopic organ from the pancreas, and then we developed a method in the 80s that is still used now by center worldwide. That is an automated method whose core is a digestion chamber that later on was named Ricordi chamber, but is a really simple core procedure where you assemble, put the pancreas after you inject a mixture of enzyme that disassemble progressively the organ, liberating these hundreds of thousands of microscopic structure that can get purified, and then you can transplant them in the liver of a patient with diabetes, with type 1 in this case, re-engineering, if you wish, the liver to become a double organ that does both the function of the liver and that of the endocrine pancreas as far as the pancreatic islets. So this has been what we've been trying to do, and now recently the phase 3 trial have been successfully completed in North America, and the procedure is approved and reimbursed in Europe and is available in many parts in the world, from Australia to Canada and UK, France, Italy, but is still considering United States. Unfortunately, FDA still regulated as a advanced cell therapy and treat islet transplant center as a drug company. So far is not available at academic centers, even if there is one company that developed and was able to go through the humps of this biologic license application in Chicago. And they may offer locally to patients there, but it's very sad that we have developed a system and a technology and trained the rest of the world who is now leaving United States center in the dust because everybody's moving forward with islet transplant everywhere except where we developed the system here.
I agree. And I also think it's pretty interesting, and I think my listeners will find it interesting that the recording method was used on season 7, episode 13 of Grey's Anatomy, and the recording chamber was also mentioned. So I'm a Grey's Anatomy fan. I was like, wow, this is crazy, because I know you personally, but I really think it's cool.
Season was and what episode, so I go drag it down because I forgot.
So it's season 7, episode 13.
Ah, okay. Thank you for that.
You're welcome, but I think it's really cool.
Another episode. You know, there was a second episode also on
Really?
it was a little later. There was another episode on a chamber that you implant. Was on a transplant procedure. At the time we were working on the biohub to eliminate systemic immunosuppression. But it was fun because they invited me to the celebration of the 300th episode of Grey's Anatomy in Los Angeles, in Beverly Hills, this big party that they throw, and they invited me because it was on one of the successful episode that they transmitted. And I arrived there and I had to call a friend of mine, this girl in Los Angeles, a model that actually knew the actors, because I had no idea what was it, because one thing that you don't do is, like, if you spend 12 hours or 14 hours in a hospital, you don't go home and turn on a hospital show.
Right.
to see out. It would be pity. So I had no idea who were the actor, but I brought a chamber and I had them sign. They all autographed the recording chamber. So it was a nice event.
Yeah, that's awesome. Well, I think it's really cool, and I think what you're doing is amazing, and the implementations can really help a lot of people. So I'm hopeful that the Ricordi chamber and the method can be used in the United States because it really is a helpful method. So what are the biggest challenges you've encountered in your research?
Well, the biggest challenge has been like silos and competition between centers. I try to apply a very open source philosophy in my professional life, like inspired by Banting and Best and Collin when they invented insulin, and they sold their patent for $1, saying insulin belongs to the world and not to us, and they wanted to free the development of insulin as a therapy. So in a little utopistic way, when I graduated from medicine, then I developed this method. I said, I'll free the patent and I give it for free to everyone worldwide. So I never enforce the patent or ask a penny as a royalty or payments. And I think this help in a way because help sharing and building and improving the method collectively instead of having a lot of competing groups trying to develop another system. And that I think helped. The challenges have been both financial funding for cure-related procedures. You didn't get back then a lot of interest from industry. Even now we have major big pharma entering the field of cell therapy. But in the 80s, 90s, and 2000, the feeling was more don't do with a cell what you can do with a drug. And then there have been also subliminal disincentive, meaning diabetes is a market of close to 300 billion a year in the United States, and erasing it from the face of the earth instead of putting what I call band-aids on a wound that never heal, like insulin or gadgets or things that are fantastic to improve the day-by-day life, but they don't eliminate the disease, they don't eradicate it, and many times they don't prevent the risk of complications that still can develop, especially later in life, in the last decades, like kidney disease, neuropathy, retinopathy, and all kind of chronic problems. So that's why we consider diabetes as an accelerated aging or premature aging disease, because you tend with these decades of inflammation and burden, you tend to exhaust faster compared to people who are not diabetic, your capacity to repair and regenerate these tissues and cells. And that's why it becomes a problem, especially later in life, even though now the improvement have been massive. But what you see is still a huge health disparities depending where you're living in the world. So you may be surprised that if this impact on accelerated aging may be around 10 years if you live in United States. And then if in United States you're smart and you have access to technology, it's probably less than that. So it's almost irrelevant or very small. But if the average in the world is that you lose 24 years of lifespan, of potential of living, if you have type 1 diabetes diagnosed at age 10 compared to a child that is not diabetic. And it's terrifying if you go to low-income countries, because this difference is 47 years. So if you're 10-year-old and you're diagnosed with type 1 diabetes, you may lose 47 years of lifespan compared to a 10-year-old child that doesn't have diabetes. So this point out on how, while we're waiting for an ultimate cure, it is critically important to access technologies and try to control as well as we can metabolic control, glucose levels, prevent glycemic variability, oscillation. And this has been a lesson not just for subjects with diabetes, but for everyone, because this is associated with a healthier lifespan of everyone. So in a way, diabetes is leading the way to indicate what things you should do to avoid an accelerated aging or losing life years in mental and physical health. So that has been an evolution, so that now we're working more not just treating the most severe cases of diabetes, waiting that someone fail and have hypoglycemia and awareness, and this very severe low blood glucose episode that can be life-threatening. And that because now the indication for islet transplantation, because of the requirement of anti-rejection drugs, are limited to these cases. But we said, what are we doing to prevent this progression? And if you know that there is this genetic risk factor, what are we doing to prevent this imbalance in your ability to modulate inflammation and immune responses, so that you can avoid that you progress towards autoantibody, this antibody start attacking the islets, and then eventually it's dysfunction, and eventually losing when you have the clinical diagnosis. So it's more like there are these stages of diseases that traditionally they've been classified as stage 1, 2, and 3. Stage 1 being when this autoantibody appear, and stage 2 when you start losing insulin-producing cells and you have irregularity in blood glucose, and stage 3 is when you have the clinical diagnosis, when that generally can be dramatic with going to the hospital or so. But what I start introducing is we have also stage 0, that is before the autoantibody. If you know that there is 1 in 300 with this genetic risk, and in the general population in general, like there are interventions we know with vitamin D, omega-3, for example. If you have an imbalance in these two very simple factors that are generic, don't cost a lot of money, you have increased risk of all autoimmune diseases. There has been a very long, huge study on tens of thousands of patients followed for decades that show that you can decrease almost 40% the incidence of all autoimmune diseases just taking vitamin D and omega-3. So that is one thing that you could teach the general population to stay healthy, like to do this. We even have a website. I put it as an open access free information on what I should suggest and what I take, that is called fitforhealthspan.org, with fit and the number 4 and healthspan.org. And this is the same suggestion that we recommend also when you have COVID, for example, if you become positive for COVID, because we found out that the same criteria that we use to prevent autoimmune or treat or decrease the severity of autoimmune diseases are the same also for viral infection like SARS-CoV-2 in COVID. And there have been a recent paper that confirmed that if you have, for example, low levels of vitamin D, you have not twice, not 4 times, but you have 14 times more probability to develop severe COVID or die from COVID. So these are very simple. And vitamin D, the supply for 2 years costs less than $20, so it's not a big burden for anyone. But probably is also a reason why nobody's really studying it a lot, because who wants to invest in multi-million in large clinical studies for something where there is no billion-dollar molecule to profit upon? So there are.
Absolutely. Thank you for sharing that. So I find your book, The Healthspan Code, I have it right here, very fascinating. Can you explain some of its key findings, specifically regarding disease prevention, like you just mentioned?
Yes, it's a book, it's an evolution, but the concept is that you don't have to wait for people to become patients to start working on curing them. So that the whole health system in the United States and most of the Western world is based on people becoming patients, going to a hospital or seeing a doctor. And then the chain of profit of healthcare starts. So then is when you have reimbursement, and the whole economic system that support medicine and healthcare is based on reimbursement for things that you do or drugs that you give in sick people, in people that become patient. But there is no reimbursement for preventing that people become patient and enter this chain of profit. So what is this chain of profit of the healthcare cost in the United States is now around 4.3 trillion a year of dollars, which is like 20% of the GDP of United States. And 90% of that, or the large majority, is spent to take care of people with chronic degenerative disease conditions, such as diabetes, chronic kidney disease, neurodegenerative disease, cardiovascular, and so on, that affect 90% of the people over 65 years of age. But in diabetes, you can have accelerated aging if you want, and have problem before even. But this is in a section of the population, the over 65, that will double in the next 20 years. So what are you going to do? Spend 40% of the GDP in healthcare will be sort of economically unsustainable. So there is also a red flags that emerged that for the first time in history, the lifespan prediction for Americans have been decreasing in the last 3 years. And now they're talking that the children born now, maybe the first generation living less than the generation of their parents. So this is why everyone, you don't have to wait to become old to get interested in Healthspan, because Healthspan medicine starts when you're a child, and even now they're talking when you're during pregnancy for the before the child is born, and so it's a continuous. It's a Healthspan start before you're born and continues when you're young and when you age and when you have your own children. And so this is the Healthspan code is based then on the realization, is what are my thoughts based on 40 years of working in this field. And many are theories, more and more are being confirmed by clinical studies, but as I say, nothing is written in stone, it's an evolving field. But the concept is that you can intercept disease progression towards even the early phase before the diagnosis, because what I call predictive diagnostics, that is different from early diagnosis. Like, you can have early diagnosis of a disease is when you do like a mammogram to detect a little lump in the breast early, or a colonoscopy to detect a little polyp in the intestine before it becomes a problem. But then you have predictive diagnostic, is a diagnosis of risk factors that are invisible, that you cannot detect, and you cannot neutralize something that you don't know. So that there are things like silent inflammation, insulin resistance, glycemic variability, the glucose level that bump, even if you're not diabetic, but every time your glucose goes above 140, that is a red flag for your long-term healthcare. And that's why now you see continuous glucose monitoring system made available also for sport, or for healthy nutrition, or for Healthspan strategies, because you don't have to be diabetic to check how your blood glucose is going, and you don't have to wear it all your life. But if you are non-diabetic and you don't need it to define your insulin dose, you can just wear it 2 weeks or 1 month and start learning what thing that you eat make these bumps in blood glucose, or what you drink, and try to then at least be aware and informed of what could be food product that you should avoid or limit, or besides of the general rules of healthy nutrition, physical exercise, as controlling the portion, and we talk in the book about anti-inflammatory nutrition, that is not just the glucose level that is determined, but also the inflammatory contribution, because there are two things, that high glucose and inflammatory molecules are synergistic. They work together to create more problems in your tissues. So it's not just glycemic index, like in the old days you were saying, just check your carb load, glycemic index, and then adjust your insulin doses. Also, the level of inflammation that you can trigger can increase substantially the amount of insulin that then you need to control. So it's all I think is an interesting book. I have a lot of people that is very happy, write to me and say, wow, why my doctor never told me about this. But you will see more and more, because now Healthspan medicine was an unknown term, because everybody was speaking about lifespan, and you have all this guru or living forever, like why we age and why we don't have to, and stuff like that, of trying to live forever, which I find it proportional to how many $1 billion you have in the bank and how many more days to live. Some people
Well,
is worried about
it's
how.
it's a really interesting book, and I think it's amazing that you not only wrote a book, but it's helping so many. It's very informative, and I myself have found it very interesting. So thank you so much for putting that out there. There was a particular concept I was interested in your book. It's the double pyramid. Would you mind explaining what this model is and its benefits for personal health and environmental sustainability?
Yeah, it's a very interesting experience that we had as part of a foundation for health and nutrition that we put together a couple of decades ago, actually. Expert from cancer, diabetes, cardiovascular, and as expert on water supply, planet, nutrition, hunger, and see what would be guidelines. It initially says, can we establish guidelines for a healthy nutrition for to prevent cancer, or healthy nutrition to prevent diabetes, healthy nutrition to prevent neurodegenerative diseases. And then the interesting fact was that actually there is not a healthy nutrition to prevent single diseases, but is all converging to guidelines that are the same to prevent all kinds of chronic degenerative diseases. And so basic principles that are very, in a way, simple and in a way complicated, and I tell you why. But the other surprise is that when the other group, focus group, was studied the impact on the ecosystem and environment and pollution and carbon print and this kind of factors, I thought wait a minute, this seems inversely proportional to the recommendation that you're giving for nutrition. And so I remember I took in the lunch break a little napkin and I drew this double pyramid concept. Say, is it possible that we have what we are proposing is actually something like this, like a double pyramid, and that's how the double pyramid started. I didn't trademark as my idea, but this was a team effort, of course. But we found that the things that you have to eat the least are the ones that have the biggest impact on the environment. So that's how it evolves. Like if you have to decrease the use of super sugar cakes and ice cream and stuff like that, or red meat, and then you look what is the red meat, for example, is a typical example that requires 1 kilogram of red meat may require 15,000 liters of water to produce. While as you go down to cereals and vegetable and fruit, this environmental impact decrease, but also the health benefit increase. But then it's complicated because also within the same category of the health pyramid as well, where we introduce the inflammatory pyramid of anti-inflammatory nutrition, is that you can have, like, if you take like carbohydrates, for example, pasta has a glycemic index that is much lower than rice or potato or white bread. And so within the same category, you can, of course, we say privilege whole wheat or, this kind of product, but is easier to look also at the imprint as far as glycemic index, and then you have to look how much omega-6 and omega-3 they contain if you want to start assessing also the inflammatory index or inflammatory potential, because we know that there are these two class of fatty acids that are essential, omega-6 and omega-3. You need both of them, but an omega-6 can be higher than omega-3, like with a ratio of 1.5 to 3, but if they become too much, they become pro-inflammatory and they can trigger development of a lot of the diseases that are associated with accelerated aging. So it's a whole ecosystem of healthy nutrition. It's not just one rule. And it can be complicated, as who wants to calculate all these things when you go to the grocery. But now I think with artificial intelligence, digital health, and all the new gadgets, you'll soon have these things that you wear, or you'll have your Google Lens and you look at the food product and say, oh, red for inflammation, good for glucose, good for both.
Come on, invent something. I'm waiting for you. Like, you should do something where we can just put something on and it can calculate it for us. Like,
yeah, if you Google like Daniel Kraft, the future of medicine, and you look at his TED conference or all kind of, is amazing the technologies that are evolving in this area, and I mean artificial intelligence applied to healthcare and including Healthspan, predictive and assessing, and soon I think in the future people will not even have to go to a hospital most of the time to try to remain healthy. You will be able to do testing. Now you can do like omega-3, omega-6, arachidonic acid over EPA ratio, that is the inflammation index, vitamin D, the autoantibodies, insulin resistance is coming out, all finger stick, postcard, and sending to a site, so you don't even need to see a doctor to check your health status in this direction.
yeah, absolutely. I find it very fascinating. And when you were talking about nutrition, I relate to it a lot. I'm currently studying to be a registered dietitian, so I'm very passionate about nutrition, and a lot of my listeners are as well. So I think your book will be able to help them tons. So you can find his book, The Healthspan Code, on Amazon, and I will also link it below. But thank you so much for sharing all of that information. It really is helpful.
My pleasure.
So you also notably researched COVID-19 and engaged in stem cell infusion research to find methods to treat the disease. What were some of your breakthrough findings?
Well, we found that was an interesting story in the sadness of the crisis of the moment, but we were working on these cells, progenitor cells that used to be called mesenchymal stem cells and now called mesenchymal stromal cells because they are not real stem cell, meaning they cannot become all kind of tissues like a real stem cell, but they're progenitor, they're immature, and they can generate a powerful anti-inflammatory and immunomodulatory response. So they can modulate the immune system and inflammation in cases where you have a hyperimmune, hyperinflammatory response. Like, for example, in COVID, the cytokine storm after a SARS-CoV-2 infection. And what has been we already had these cells approved for trials in type 1 diabetes when the COVID, because this anti-inflammatory immunomodulatory property, we wanted to test to see if we can block the progression of type 1 diabetes, as we already show in the past, that can block the progression of chronic complications in long-term diabetes. But then we were all blocked, like during the COVID pandemic, we couldn't do any more diabetes trial and not judge a priority or emergencies, but at the same time we had an ICU full of people intubated and dying. So I got a very fast, I thought if we have these cells are supposed to be anti-inflammatory and immunomodulatory, and if you inject them in a vein, they naturally go to the lung as first passage. Why don't we try to infuse these cells in the most severe cases of COVID-19 that were in the intensive care units, intubated or on ventilators, etc. And FDA gave us the approval very quickly, but they said you can do it, but has to be a double-blind randomized controlled trial, which means you flip a coin. Some people get the cells in the infusion and other gets just the solution without the cells, and nobody, the patient or the doctor, of course, the patient often were intubated and not, they wouldn't know anyway what to infuse, but the doctor and the family and didn't know what was receiving. And to our surprise, I was expecting like a significant positive effect, but was overwhelming. We were able to save all people treated, 100% of people below age 85, and we lost only one patient because of the family. The family had an order, do not resuscitate, do not intubate. In the first day, you have to do anything possible to keep the patient alive. And then, so in some cases, your family is the biggest risk factor against treatment. But it was a sad situation, but it was amazing that we could save all of these patients. And in the control group that didn't receive the cells, but only the solution, unfortunately, 58% died within a month. So there was 42% survival. And also the time to recovery was amazing because 80% of the people treated were recovered within 2 weeks, while the few that survived in the control group, 80% were still in the hospital after 1 month. So with both for patient survival and time to recovery. So this is important because now we can plan this kind of strategies in other lung disease, inflammatory disease, but created also the basis to support this kind of therapy for also autoimmune disease condition like type 1 diabetes. We're starting a trial now and others, but what cells did we use is another fascinating thing because we use cells extracted and expanded from the umbilical cord of a healthy newborn baby. So they're not fetal or embryonic stem cells, they're postnatal. When a healthy baby born, instead of throwing away the umbilical cord with the placenta, we know some people bank the cord blood, but this is not the cord blood. This is in the wall of the vessel of the umbilical cord. There are these very mature cells that are of baby origin, most of them, and they have an amazing power to expand. So from a single baby umbilical cord, we can expand hundreds of billions of these cells, enough to treat 15,000 to 20,000 adult people with a cell dose of 200 million per subject. So is a potentially there is no shortage of, like you have in organ transplant, and unfortunately over 11,000 people die for lack of donor organs, and there is the problem to try to improve organ donation. But in this case, if you think every baby newborn healthy can save or treat 15 to 20,000 people is amazing, because you don't have, like just in our hospital in Miami, if you have over 10,000 newborns a year, you have plenty of cells to potentially treat or cure everyone you want. So this is I think is an amazing new development that emerged from these initial findings, and we've been working with these cells actually for decades, because we started in kidney transplant recipients to decrease immunosuppression because of the immunomodulatory effect, then in long-term diabetes to see if we can treat the underlying autoimmunity and regenerate some insulin-producing cells. And to our surprise, we saw that you can prevent the development of nephropathy, neuropathy, and retinopathy. So then say, wait a minute, if you can prevent, maybe you can intercept disease progression at the beginning without waiting to have long-term diabetes. So it's an evolving field, but it's incredibly interesting, and I think you will learn much more in the next month or years.
Yeah, absolutely. And I will definitely keep up to date with all you're doing. I think it's amazing what you're doing for health, and you're really changing a lot of lives. So thank you so much for what you do. To end this podcast, for my everyday listeners, could you briefly summarize some key strategies they can incorporate into their daily lives to prevent disease formation and progression?
Yes, in the next 2 hours, I will summarize. Not kidding, but I have when I do this lecture for students or healthcare providers or general public, I have 2 slides that I particularly like, that are one, you see, you have, I put on a chair, on a platform, I put the bottle of super alcoholic, and then a pack of cigarettes, and then a hamburger with French fries, and then a cake with cream. And then I start asking the audience, which one do you think is the worst risk factor for your healthy aging and ability to live long in mental and physical health? Then you start all the raising hands, the cigarette, now it's the whiskey, now it's the hamburger, now it's the cake, and then I switch to the next slide, and it's the chair, is sitting, is the sedentary lifestyle, is the worst risk factor for healthy aging. And of course, all the other factors are not good either. But if you want to start with the best thing that you can do to maintain physical and mental health, is physical activity and exercise, which is also incredibly cheap, because you can just take a walk for 1 hour or 30 minutes every day. You don't need to have very expensive equipment, even though if you have access to something like that, it helps. or reducing the time that you need to walk or exercise. But so that's the first big thing. And then diet combined with physical exercise or physical activities is important too. So if you combine these two factors already, healthy nutrition and physical activity, you can, for example, reduce the incidence of diabetes by more than 50%. So you could go from this 450 million worldwide to maybe less than 200 million, but still is not completely a home run. And the interesting thing is that we used to say diet has nothing to do with type 1 diabetes and autoimmune diseases, but now is emerging from these studies and what you read also in the book that there are some element of risk factor that are contributing to this imbalance that may impede your immune system to fight an immune reaction or an inflammation that is a triggering event to autoimmunity or to COVID or to age-related diseases. So it's all coming together in a way that there is a Healthspan ecosystem that you can consider, and the solution is, or the final take-home message is there is not a single bullet or magic remedy. Like you cannot take your pill of omega-3 or vitamin D, say I'm doing my job for Healthspan, you know, you cannot just exercise and then say, okay, now I go eat 5 pizza and my ice cream. It's an ecosystem, so it's a combination of all of these factors, including also protective molecules that you may not assume sufficiently with the diet, because polyphenols or sirtuin activator, that is something you'll start worrying more after age 35, but vitamin D and omega-3, you can start balancing them already before. And so it's a combination of factors, and on chapter 9, you have a summary of all what we've been discussing, if you don't want to read all about the history of my life before.
Well, thank you so much for sharing that and for joining me today. I really enjoyed our conversation, and I think it will really inspire and educate my listeners.
Great. Well, I'm happy to be on your podcast, and I hope that you and your listening enjoyed it too.
Well, thank you so much. Thanks for listening to this new episode of the Take Care Your Body by Rye podcast with world-renowned Dr. Camillo Ricordi. His book, The Healthspan Code, can be found on Amazon. I hope you learned something new and a little bit more about taking care of you. Thanks for listening, and as always, with love, Rye.